Welcome to Kimecast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. Welcome to Kimecast. This is Tony Mikla with Aaron Crouch, Russ Dunning, and we're honored to have Dr. Hunter Greene tonight. So super excited. We've gotten to work together for quite a while and gotten to spend quite a bit of time in the clinic together as well. So this will be a lot of fun to talk about. We want to talk about some new advances that's going on in orthopedic surgery, some things we're seeing, and we'll talk a lot about tissue healing and just patients in general and how we can help them, how we work together and collaborate. I think is always good, always insightful. So we'll rock and roll. But first, tonight we're changing it up. We're raising the bar here to
the literal bar.
Yeah, from the normal beer to wine. So this is going to be cool. So Hunter, you want to show us what we got here?
Sure, yeah. So this is Davis Estates. They're out of Napa Valley, kind of on the border of Calistoga area off the Silverado Trail. It's a beautiful winery. The owner is he was a tech guy from San Diego. Came up and loved wine and built this beautiful place. They got the property. It looks across to the west, across the Napa Valley there. Beautiful, beautiful location. In the recent fires, a fire came over the crest of the mountains. And they were able to hold it right there. They lost two accessory buildings, but they have this old barn from like the 1900s that they do parties in that survived. The winery survived, but they did lose two kind of accessory homes. But they were just so thankful that. And then actually on Yahoo you had a picture of their estate with the flames behind the hill on the hill.
Oh wow!
And it's interesting because there's a family of bears that live up in the hill, and hopefully. We don't know because they said they haven't seen them yet, but it's wintertime, so hopefully they survived.
Yeah, right. That's crazy.
But yeah, this is a 2018 Pinot. They make beautiful wine, so enjoy.
Cool. Well, thanks for bringing it. Yeah.
Absolutely, yeah.
Cheers. Thank you guys.
Cheers.
Rock and roll. So let's talk very good. Some surgical stuff. And we're honored to have Hunter here, who's really one of the finest surgeons we've had the privilege to work with over several years, which makes our job super easy, which is great. Yeah. And then as things have evolved, as technology has evolved, and maybe some of them don't know this, but the process of surgery, especially orthopedics, has gone from large open incisions to arthroscopy, which has been around for the better part of at least 25, 30 years now. But even within that, the advancements on probably a 6-month to annual basis of using these different tools and equipment to make it even cleaner, so there's less collateral damage and kind of easier access to stuff. I know that you do a lot of work with the hips, has been a big focus, but certainly shoulders and knees as well. So,
yeah, I mean, to that point, in the olden days of orthopedics was, the bloodier the better. I mean, there wasn't blood on the walls. You didn't do a right operation, and it was
come a long way.
And instead of minimally invasive, it was maximally invasive surgery. I mean, because the old school was, expose everything. The old school fracture repair was get every piece back to where it belongs. This is like the German thought process of, they're very organized, very neat people. And so you had to put every little piece back together. So you'd strip the bone completely of all the periosteum, expose the whole thing, put all the pieces back together, slam a bunch of metal in there, and hope.
And the picture looks good.
Yeah. Well, your X-rays were phenomenal.
Yeah, rehab process.
But the soft tissue damage of splitting these muscles, elevating all this tissue, was devastating. And didn't always heal because you devascularize these large portions of the bone that need this vascular supply to heal. And you have this huge incision. My brother-in-law is a perfect example. He was skiing in Mammoth, broke his femur, and had a fairly comminuted or kind of broken up femur fracture. And the guy went in there and put this beautiful plate, put all the pieces, the inner frag screws, this and that, but just stripped the bejesus out of his tissue. My brother-in-law is a triathlete, so he's a fit, healthy guy, doing all these things. Went on to non-union. Doesn't smoke, eats right, exercises. Why would this young guy go on to non-unions? Because, when I saw the X-rays, I'm like, that's not going to turn out well. I mean, it's just because beautiful X-ray.
Yeah. It was almost too neat.
But not respecting the biology. Not respecting the biology of what's there, what you need to heal. This guy could have done a minimally invasive technique, did some good fixation below the fracture. Now with all these our locking plates, everything else that, some secure fixation above, leave that comminuted section alone. We know that that's all going to heal. It's not a joint. We don't have to have it perfect. You work on alignment. You get the alignment good. It doesn't matter what the middle of it looks like. We know that. We rod stuff all the time like that. big blasted middle of the femur, put a rod above and below, alignment's good, length is restored, rotation's fine, it's going to heal. They're going to do great. But when you destroy the tissues around it, they don't do great because the bone doesn't have to move. Everything around the bone has to move. So if you destroy those tissues around that have to move, muscle doesn't heal well. It scars. Bone's the only tissue other than liver that heals with bone, doesn't scar. There's no scar tissues in bone, so it's always going to be fine. It's going to go back to bone. It doesn't even care. Whether there's a lump of it or whatever. But everything else heals with scar tissue. And it's you guys to move that.
I love that from always from a surgeon perspective. It's so cool, like the faith that surgeons have in the body's ability to heal, which obviously is massive. We have the same faith, but it's incredible in watching people be like, it looks pretty mangled, but it'll be fine. And people are like, I don't know if it's going to be fine. We're like, it'll be fine. And then even surgeons that are injured themselves are like, it'll be fine. Heal up. I messed it up, but it'll be fine.
Yeah, for people that operate on people all the time, we don't want to be operated on. You find ways not to have surgery. It'll be okay. It'll be all right. So, and I think one of the things you kind of talked about is our role together. It's patient selection, picking the right patients with the right operation. And I always tell my patients, I've got the easiest part. I get an hour with you in the OR, do my thing. You have the next 6 months to make it better. I have the easiest part of this role. You have to put the everyday work in. You guys have to put the everyday work in. I always tell them, your relationship with your therapist is going to be far greater than it will be with me. I'll see you at 2 weeks, 6 weeks, 3 months, 6 months, and sayonara. We're done with this relationship. You guys, you see them twice a week, if not more. Stay in touch with them. You're their confidant. I mean, this is we talk about ourselves in clinic as being the cheerleaders. It's like, no, they're like, oh yeah, you're doing great, look good, yeah, no, because we talked about this as far as expectations. Patients have expectations which they shouldn't have. I've done thousands of surgeries. I know what to expect when I do this operation in this person with this rotator cuff tear or this labral tear. I've seen enough that I know where it's going to go. But it's their first one usually. But yet they think they know where they should go. If I ask you, hey, what's it like to skydive out of a plane? I don't know, I've never done it. Well, what's it like? And you're like, I don't know, I've never done it. But with surgery, I operate a knee well, this should be this way. Why do you think that?
Yes.
There's no reason you should think that. You've never had this before, and you're just either you heard from someone else who had the same operation.
I've
never seen
exactly the same. Right, exactly.
I've never seen the same rotator cuff tear in anybody. They're all torn, yes, but it doesn't look like the other one I did. That'd be easy. Then we just need one implant to fix this thing because it's always the same. It's like a car part, Spark plugs. Yep, put them in. There we go. We're good. But I mean, everyone's different, and I love when people say, "Oh, they had the same thing." No, they didn't. No.
Completely individualized. That's such a strong conversation that we have with all our clients, and I can tell you what we've done for this rehab for this certain surgery with these select amount of people, but you're going to have a completely different response than what they had based on your own even personal experiences, not even just your tissue.
And that's what I love what you guys do is it's not a protocol. It's not okay, it's week 5 and after your ACL, and we needed to be doing this. Okay, well that's I'm not the paper. I'm me. I'm here, and that's where you guys are so good at individualizing, feeling, knowing where they're at. You could be an 8-weeker at 5 weeks. You could be a 2-weeker at 5 weeks. You don't know, but
Exactly.
You have to adapt and move to make wherever they are. You have to come to them, and then try to get them back on track. Or slow them down from getting too far ahead of themselves. And that's the kind of the art of medicine and everything that we do is individualizing a kind of global thought of where you need to be. You have the goal, okay, we want you back to basketball. Okay, we're getting there. Everybody wants to get back to basketball that's doing that. But the road to get there is, Apple Math has 3 choices.
I think you're touching on something that's so relevant because people right now, they have surgery and then they Google different protocols and they bring all 4 different variations of a protocol to the PT clinic or even the doctor will reference the protocol. Hey, it's 12 weeks. They should be good to go here. In reality, your relationship with the surgeon as a therapist and your understanding of that person's custom needs is so essential because the protocol is just kind of loose. They're all loose, just shotgun approach. And what's more important is the week-to-week progression. Not too fast, not too slow. Feels good. and we stay the course there. And then what I love is reading op notes, reading the operative notes of not to know that I'm going to be able to understand everything in the operative note, but I'm looking for some three key words: mild, moderate, and severe. When I look at that stuff, and if I see a lot of severes, like I might want to chat with the doctor about this. Is this going to be pretty easy, chill rehab process, or is it going to be aggressive, or how are we going to negotiate those things, because they're all different for each person.
I frequently look back at either my op note or the arthroscopic photos if someone's not where I think they should be, and it's okay. We're 3 months out, still got some swelling. What's going on? Let's go back at pictures. That's right. You got that chondral wear on the end of the condyle. That's probably why we're slow. That's okay. We can get there. We're just a little slower than we expect because you've got this going on. And they always go, oh, yeah, okay. Show them pictures. Remember this part? Oh, yeah, okay. So that's why we're taking a little more time.
Yeah.
We got to get a little more strength in there, got a little bit, going. But that's why we're not on the kind of trajectory that your friends were on that had the same surgery,
Right.
So that sort of being able to look back and I'll go back and read my op note. Okay. Oh, yeah, okay. They had some more advanced chondral wear or had this big chondral lesion in the acetabulum. And okay, well, that's going to slow you down a little bit. And I always talk to my patient about, now that we know what we have, we got to make good choices. If you got chondral lesion in your hip, we're not going to think about running. We're just not going to do that. That's not a hip-friendly activity. We're not doing that.
Yep.
You got to make smart choices with what you're doing moving forward, knowing what's now going on. We've been in there. We know what's going on. Doesn't mean you can't do certain things, because we've had people that have these bad things and they get back and I always challenge them. Hey, prove me wrong. I'll admit I was wrong. You got back to it. You feel great. That's fine.
Absolutely.
But in general, you got to be careful when we know what's going on. And that's great that you guys look at those things. And when a therapist calls me, hey, I was reading your op report.
All right. I feel honored.
Cool. Find some misspelling. But that just shows that kind of level of care to take care of the patient, this patient, not a protocol patient, but this patient, and what happened to them in the OR at that time. Our op reports are sort of like your resume. It's always the best picture of what happened. It's not always the oh yeah, well this anchor went in and out and
On the fourth attempt.
but there's certain things. There's a level of honesty you have to kind of bring into that. If that anchor pulled out, the bone quality is bad, we then went to this, and so because there's times when you get in there and you just dunk it in, and there's a big old cyst in there, and that's not holding right, and then you got to go to Plan B. And kind of move and adapt to whatever you're given in the OR, because you can't reset. Let's try that again.
Right. That's the critical thinking then. I think that people think, I'm going to have surgery, whether it be rotator cuff or hip labrum or ACL or whatever. It's like, I'm going to have the surgery, and it's just that. And it's like, well, you realize that the person you're hiring needs to be critically thinking in that moment, because, to your point, you come in and do it. It's not like there's just one thing to put in. You have a tray of options, quite a few trays, as a matter of fact. In most cases,
For a
all the
reason.
different options, just in case something went a little awry, or I saw something that I wasn't ready for. I was like, okay, we need this different size anchors, different types of drills, different types of security methods, different sutures, different knot strategies, lots of options to solve these problems. So
that's the we always tell you, Plan A is this. Plan B is this. And sometimes we're going to need some bigger options over here. Because typically you go in with a plan and, we're going to run down this path, and rarely do we get bumped off or a little speed bump. Okay, we can just alter that. But sometimes going in, especially in a revision setting, we're going to have some backups over here because we don't know exactly what we're going to get when we get in there. Because that's the revision setting. They've had surgery before. You don't know what the tissue is going to be like. You don't know what the guy did before, if it wasn't you, or if it was you, what you did before. And so those are guaranteed. Hey, we've got allograft backup. We got a graft in place. We got this, and that's the strategy where you have to kind of really think on your feet. And some patients get that, okay, so you're going to decide once you get in there. Yeah, I'm kind of gonna. It's a game time decision sort of thing. This is we're going to figure out what's best for you at that time when we're in there. And there's a great term called functional fixedness. And it's okay, this is a wine glass, but what else can it do? You can turn it over, you can stack stuff on it, you can do that, you can so there's ability to look outside that box of what something can do. And we do that a lot in orthopedics because sometimes we don't have the tool we need, so we need to make the tool we need from what we have in the back table and figure it out. We just dropped the mallet. Dang it. Okay, well, I'm going to grab the drill and use the drill again because it
It's
works.
the only one I had that was sterile.
Yeah.
So
That's why you're like, all right, you just adapted, and so you don't want a surgeon that has functional fixedness,
Right.
because then you can only see what it's intended for, not what else it could be.
You're MacGyver in there.
Yes.
You got to be MacGyver.
Yes, exactly. You know, and unfortunately, most of the time you don't want to do that because you
right.
want that first path. But if you get into that situation where you're throwing a curveball and okay, where do we go from here? And there's times you gotta just step back and gather your thoughts, and because you get lost in the moment a little bit. And younger surgeons get this a lot where they're just so tunnel visioned in on what's going on. It's, you just gotta step away from the field for a second, gather your thoughts, take a deep breath. One of the guys that I trained with was great. He's like, if you're ever stuck in a case, just irrigate. It'll give you time to think.
Just irrigate.
And it's a good thing too, because then you're cleaning the wound and reducing the risk of infection. So it's like good, So it's like
Start humming to yourself.
yeah. But it is. You just and it's great when you have an OR team that you worked with a lot, and they know you and they kind of know how you go, and they know like, oh, he's thinking. And they also got to see how but you got to diverge off that path, get lost in the woods a little bit, but all right, let's get ourselves back on that trail. We know where the trail is. We just got to get back to it and find a way to the end. But it's tough and it struggles, and you always the rule is always leave the OR happy. Never leave the OR unsatisfied. And so you just leave the OR happy. You're there. You've reached the goal. You've done the best that you can for your patient, given what they gave you. Because sometimes these like talk about fractures.
Yeah, the tissue like
It's as good as it's going to get, and we always say the enemy of good is better, and trying to make something, you get fracture reductions, you're looking at it like, can I make it? Okay, no, I'm not going to make it better. We're going to buy this. We're going to be good. You start pulling screws in and out. It's like, it's just going to just fall apart. So it's
to make this really real. We had a client that you saw a couple weeks ago. I just evaluated the gentleman the other day. And he's a non-surgical situation, but it was a mechanical engineer, and we've talked about different types of patients and stuff, so he's very, very, I want to know exactly what we're doing.
They understand. They said material properties of things.
Yes, they did.
Yeah, but you're a human.
Exactly, yeah. So, we started, the conversation started off with, here's my MRI, instead of, here's my shoulder and here's how it feels, right? So it was interesting, and of course it was 50% partial thickness tear, and then there was a slap lesion as well that was identified. So I had not asked him to raise his arm yet. I don't have any idea what the pain level is at, and so he's like, what do you think about that? I'm like, well, I'll tell you this, and this is from working together with good docs and knowing that there's a decision-making process here. I'm like, well, I'll tell you this. If you're sitting here in front of me today from Dr. Greene and you had not had surgery, I'm assuming that you function fairly high, and he saw the image and elected that he could operate on 50% partial tear, but he doesn't have to. And so let's talk about that and say, so this is what we can do. This is the physiology of how we can make this tendon change and evolve, et cetera. And then he's like, okay, yeah, it makes sense, but it's 50% torn. I'm like, yeah, I understand that, but let's go through and let's. And then he raises his arms up, and he's got like 165 degrees. And I do his strength testing, and he's strong, and I'm like, this is why you're here. Because we could make you worse in the OR in your situation. And it's not like, oh, my cuff is torn, it has to be fixed. My cuff is damaged and certainly maybe torn, but everybody else's is too over the age of 40. Yeah. It's a degree of how much and how does that affect your function, and then that's where the decision tree really comes in.
And we talked a little about being greedy. And if this is 100%, you're here, surgery's probably not going to get you there. You're down here, we can get you here.
Yes.
And I always tell people, like this guy exactly. If I operate on you and you look like this afterwards, I pat myself on the back. Good job.
Yeah, right.
All right, way to go. But you're already there. We can just see if we can make you a little better from where you are. And try to either give you realistic expectations to what you should expect to do with the shoulder, or break those and see if we can get you better. But the my MRI says, oh, that's bad. If I was going to operate on an MRI, I would operate on an MRI. That's fine. But I'm not going to operate on you, because I've operated on that MRI before and had good success, but it looked different than you. And so this whole concept of what my MRI shows, and we know from great studies, like you said, slap lesions, exceedingly common. Meniscus tears, exceedingly common. You just have to, is your meniscus tear the cause of your pain?
Yeah.
I know it's on the MRI. Yeah, that's fine. It's a cloud in the sky. Is it going to rain? I don't know. Do you know it's going to rain? Because there's a cloud up there? I don't know. It's like, is that going to produce rain or not? I don't know. We're going to have to wait and see. And so that's the whole thing when people come in. Labral tears, exceedingly common.
Yeah.
But likely if you're coming to see me because you found a labral tear in MRI, something was bothering you enough to do that. But it's these people that get in car accidents and things like that, and you get an MRI. Oh, I have a labral tear. Great. It wasn't from a car accident, but you found one.
Right. I think like an interesting, like when you shed light on those conversations when someone brings up their imaging, I always like to ask, well, did you get a pre-injury image as well? Like you're going to compare it to? Like how do you know that didn't pre-exist? Like pretty much all the research says you could image an entire room of people and half of them are going to have some pathology in their tissue, whether it's a labral tear or if it's a meniscus tear or even protruded disc, you know? And even maybe a third or a quarter of those people might feel pain. Right. So there are plenty of people walking around with damaged tissue that have, zero limitation to their life. And I think that truth to the client is like, oh. Okay.
Yeah, I tell that all the time with we don't know how many people have them because we don't MRI everybody, because they're fine. I always tell them, you could have a meniscus tear in your other knee. You probably do. Yeah. Well, that one's fine. Exactly. Yeah. That's fine. But, so you have to, but that's where the clinical side of what we do is we have this objective image on an MRI or X-ray or what it happens to be. Because I've seen bone-on-bone arthritic hip. Guy rides his bike 200 miles a week. All right, go away,
Yeah,
it's one of those things that, and then you have a hip that has no problems and they can't walk. All right, so we got to figure these things out. Like these are two drastically different things, but also very drastic clinical pictures. And so, is your meniscus tear the source of your pain? And that's what we get to do and try to figure that out clinically. And then, if we think it is, can you guys help them without us having to do something surgically to them? Because not every meniscus tear needs surgery. Not every labral tear needs surgery. Not every cuff tear needs surgery.
Yeah.
My favorite is these old guys that come in with, high rated humeral head, obviously no cuff. Someone got an MRI and they're atrophied all around. Arm goes way up. They do that. Strength isn't great, and that's what they want. Right? There's no chance of getting any strength. Do you have any pain? No. Okay. Yeah. Once again, and then that comes up time and again. Like, if you look like this after surgery, I'd be pretty happy. And they're like, but I want strength. I said, well, nothing I can do will give you what you want. But I said, fortunately for you, there's a lot of people that have pain, can't raise their arm over the head, and you've got all those things, and that's what I can restore with surgery. But you're already there. Yep. You don't need it. And you can operate on them. Like. You can operate on every partial thickness cuff tear. Sure. Absolutely. Sure. And look great. Yeah. Because they're going to do great no matter what. That's the one thing. So you have to, there's some level of, do you need this? And it's hard to convince some people. Yeah. A guy like this. Yeah. You're going to be okay. But I know. Yeah. I know what it shows.
Imagine you didn't see that.
Yeah, right.
Yeah. Should we MRI your other shoulder? Just to see?
Yes.
That one's going to start hurting pretty
soon.
soon.
Yeah, right. And it might perseverate on like two shoulders now.
Sometimes you don't want to open that box. But and one thing that I wanted to kind of touch on a little bit, because this is things that I talk a lot about patients where you guys can come in and once again having them have an understanding is it's the three S's. I talk about strength, stability, and stamina. So you have to have good strength, stability around the joints, and good stamina and things like that. So, and a lot of that stability thing comes from either they're overly lax, so that's the flexibility side or stretchiness of them. So some people are overly stretchy, so they need more strength to create that stability, or they're overly stiff. And it's guys and gals have different amounts of that. Young guys tend to be a little stiffer. Young girls tend to be a little more lax. So we have to kind of balance those categories of what it is, and that's where you guys get to do that great assessment. Take a look at them, say like, you can leg press 400 pounds. That's great, but you can't touch your toes for that.
Bit of a problem.
Yeah, right. So we're gonna stay off that machine. We know you can kill it. But we're gonna come over here and try to find be able to reach down and touch your toes.
So true.
And then these people that can do all this stuff but can't run for 10 minutes, without, falling over. And so the balancing those things is so important for just, our general overall, joint health, whatever you want to kind of call it. But those things I think I try to emphasize over and over again with people in either the non-operative phase or even in the operative phase, because operatively we ruin a lot of those things.
Yeah.
We take away, we put them in a sling for 6 weeks. Okay, well, now we're going to be stiff and weak and not be able to, do anything. And I tell them early on, it's like, going out to get the mail is going to be like running a marathon to you. I mean, it's they have all these expectations of what I could do before and this and that, but no, it's all game's different after surgery or after injury. Because even with an injury, you take time off, you rest, and people, a couple days of rest ruins you. I mean, you've all seen how quickly a quad goes away after an ACL.
Oh,
I mean,
Rapid. Right before your eyes, you can watch that thing just go away.
Wasting away.
You blink.
And then it's 9 months to make it come back. Those sort of things.
If done well.
If done well.
Yeah.
So those are the things where you're just trying to educate them and having that balance of where they are. Okay, well, you're really flexible, but not really strong. So that flexibility helps you with your sport as a ballerina or gymnast, but having that strength will make you a better athlete. And if you kind of give them why you need to do it, I think that helps. Not just we have to do this cause, but how it's going to make you better. And I remember this one kid, I think a soccer player, and some knee injury or something like that. But you guys have worked with him, and while he was recovering, worked on his core, his glutes, the other things that are important to be a good athlete, sort of thing. And then he came back. He's like, they couldn't move me on the field. I used to get knocked around a lot. But now I can just feel I'm stronger. They can't move me around as much. I'm like, you're better because of this. And I mean, 100% with the ACL kids, I always tell them, hey, you're going to be a better athlete after this than you were before, because you're going to know how your body works a lot better. You're going to know how to train a lot better. You're going to know how to protect yourself a lot better. You're going to be in better shape than you ever were, because when it works, you don't have to work at it. When things are good, it's like you just go out, you just throw your cleats on and go. Now I got to warm up. I got to train. I've got to not only train my sport, but train other aspects of it, my strength aspect, my flexibility aspect, my stamina aspect, so I can be a better athlete. And it's just, I tell them, hey, everybody wants to get an A on the test. Nobody wants to do the homework. And PT's the homework so you can score well on the test. And the test is your sport. And so I always tell them that, like, I know this part's going to suck. It's not going to be fun. Like ACLs, it's 3 to 6 months is your Groundhog Day. It's the same thing over and over again. But
That's a great analogy.
Rinse, repeat.
Absolutely.
It is
So
totally
that's the.
I love the perspective that you have, because I mean, he comes from an athletic background, if you guys don't know. So played tennis in college, and then I did some personal training before you went to orthopedic. So it's like you know what it's like to coach someone, train someone, the load it takes. I think that's a huge perspective when it goes into that decision making, and then of course that rehab process. So we got to see some cool stuff. Speaking of imaging and such, when we spent a lot of time in the clinic together, and I just remember this one case was a young guy, young kid. I think he was like 11 or 12 years old, and he broke his forearm on the monkey bars, like they all do, right? And
Monkey bars and motorcycles.
And something happened where they had gone to urgent care, or they did not go to urgent care. I can't remember what happened, but they really, it had been about 6 days since the fracture, and the kid had been just with his arm by his side and saying it hurts, and for whatever reason, no action was taken. So you imaged it and just an X-ray, and we looked at it in there, and I remember seeing it, and we're like, man, it's it's angled, it doesn't look good, it's not aligned, and I hadn't got to see you set a fracture, so I was like, oh man, 6 days after the fracture, I could see like a clear fracture. It was like black in between both bones. Like, oh, this would be cool. So because it was pretty clean, I'm like, oh, are we just gonna set this? Maybe we'll get a chance. Maybe I can help him. I'm like, so you're gonna set that in the room or what? And you're like, nah, man, there's no chance we can move that thing. I'm like, what do you mean? It's like, look at, there's 2 bones, like clearly broken. And you're like, dude, that thing's solid. I'd have to take it to the OR, and even then I'd have to break it because that bone callus forms so rapidly and so quickly, and it's solid even though it doesn't show up on the image. And I think I took a lot from that, and just that experience and that knowledge. And I think that we underestimate certainly how live bone is and how fast it can heal. And in our field,
when you're young,
right, true. We figure, we talk about bone healing as like a 6-week process, 6 to 8 week process, to really solidify and harden. And a lot of people see that, but I thought that was really amazing. That 6 days, the perspective was, that sucker's pretty solid already.
Yeah, you've got a 10-day-old distal radius fracture and a 6-year-old. I can still reduce that in clinic, no problem. It's not gonna, it hasn't had that. When you get a young kid like that, I mean, within a week or two, I mean, typically, clavicle fracture. By 2 weeks, that kid's not having any pain. I literally saw a kid who's, I think, 15, clavicle fracture, skier, comes in, he's 4 weeks out, and I kind of tell him, all right, 2 weeks, you're kind of good through here, a little sore, but by 2 weeks, well, pretty much the pain's gone. 4 weeks, you can kind of get to here. 6 weeks, you're here. He's 4 weeks, he's here. Like, all right,
Yeah, sure.
And
There we
no
go.
pain.
You win.
You got the nice, and you can feel, X-ray wise, you can. It's better. You've seen some early remodeling of the fracture, but still not that bridging callus that we see. But you can feel he's just got this lump over, And I said, oh, that'll smooth out over time. But it's that, what your body's doing to splint that internally, is great. And, and like I said, with those young kids, it's when we see them that, in that 7 to 10 days, you're like, you bought it. But phone remodels at that age, so they have a great ability to remodel and change, where our bones won't remodel anymore. They'll heal, but they won't remodel. And so that's the greatest thing, these humerus fractures in these kids. I mean, they can be, 60 degrees off, and it's like, that'll be fine. And the parents are like, really? And they get the book. I used to get, I wasn't, experienced enough in practice and not enough gray hair to kind of tell parents, like, it's going to be right. So you go get the book. Like, here's a picture of this kid like you. That looks bloop, bloop, bloop. There it is. Oh, okay.
There you go.
And parents are, as you know, you have to. They have a lot of stakeholders.
They want the best.
Sure.
And, they're like, but can't you? We don't need to. Yeah, I can. But do you want your kid to go under anesthesia and all that stuff when he's going to be the same regardless of what we do? No. Okay. So.
Yeah.
That's the big point is knowing when not to do something.
Yeah.
And then I think you were talking a little bit about some of the technical advances of what we do, and man, it's really. I've been in orthopedics 15 years now in practice here, but 20 years as far as since I started training, and even then, I mean, when I finished training, this was long ago, but not that long ago. I mean, 2004, 2005. That was still just the emergence of a lot of the arthroscopic shoulder stuff. People were still doing midi-open cuffs.
Yep.
ACLs had kind of been dialed in since about the 90s. I mean, people are doing arthroscopic ACLs. What we do with that is a change as far as our fixation and how we drill, and now it's all inside techniques, so we really don't have to breach as much cortex, and we can be better to the tissues around the joint. So that's gotten a lot better as far as how we fix things and how we treat the joint. But with shoulders, I mean, at the time, that's why I wanted to do my fellowship, is to learn arthroscopic advanced stuff for shoulders, because I learned in residency, we were doing mini open cuff repairs. We had one guy who had come back from a fellowship just as I was finishing to learn how to do arthroscopic cuffs, but still, it's a little bit of a struggle still. You're tying things, you got all this stuff going on, and
it's about angle. Like getting the mini open on allowed you to get a little better angle, a little better fixation, is my understanding. Versus at that time.
Well, because you're doing bone tunnels.
Yeah.
So you're doing bone tunnels through the tuberosity and pulling it down that way and tying over a little bone bridge, and that worked great. I mean, then as things evolved, now it's like, you can see so much better with the scope than you can with a mini open. I mean, it's just anytime you have to open anything, like, this is horrible. With the scope, it's like, glorious. You can see it clear. So it's that side of it is really advanced as far as we have to hold our cuffs back now. Before it's like, I'm not moving this thing at all, because I tried to move it and I was about to die. I throwing them in like it's gonna fall over. Now it's like, I see him back. And they're 2 weeks, and they're like, this is not too bad. No, it's okay. It feels good. No, I know it feels good. Don't do this.
Indeed.
It's like you have to slow them down, because we're getting in such rigid fixation that they feel good really soon. And I've kind of, on my smaller cuff tears, I'm letting just 4 weeks in a sling and get them moving. And it's not uncommon to see them back at 2 to 3 months, and they've got active motion to here, and it's like, wow, that's crazy. And they feel great. And you're just like, okay, you feel great, but it's still biology. We can't change that biologic clock. Right. And especially in this cuff age, you got these people that is remarkable as far as what we can do now. And when you see people, occasionally I'll come across these operating reports, did it open acromioplasty? Like, you did what? Why? Do you hate this person? Yeah. It's strange when you see those things, and some people still will do open for like subscaps because that's a challenging sort of thing. So, that's not a big deal. Some things are still then open, but our ability to do so much arthroscopic and really treat a lot of the shoulder stuff that way. And then in regard to hip, I kind of started fellowship, and the guy I was doing my fellowship with was learning hips as well. So we learned together, and from back then it was just getting the scope in the hip and debriding some labrum and playing around with the bone a little bit.
Yeah, it was a brand new surgery at that time.
Yeah.
It was just coming out.
So, some guys, isolated places, had been doing it for a long time. But as far as it's really not even a mass thing yet. And it's still, even a big area like we are in Sacramento, there's still only a handful of guys that do it.
Yeah.
And, and even fewer that do it a lot.
Yeah.
So the arthroscopic approach to that is like, you're kind of adapting other things, because early on, everything was kind of adapted towards hip. Didn't have hip length anchors, so you're hoping that your patient was small enough that you could get a shoulder device in there to pass things through this and that. Then the instrument started to come around, and now we have like a whole plethora of things that we can we've got cannulas and anchors, and we got knotless anchors, tying anchors, getting there so where we can start to treat more cartilage lesions in the hip. We can do some microfracture, because you don't understand, when you have an acetabium like this and your angle is coming in like this, it's really hard to drill 90 degrees off.
Yeah.
So, and the lesions are never where you want them to be. They're always where you can't get to them.
Yeah.
And so they have these now, these flexible drills now that can kind of basically go around a 90-degree curve and drill. But these things are delicate. You can't really lever on them too much because it's a small drill and it's a bendy drill and it can break. So you have to be really careful when you're doing these things. But our ability to approach and attack these things and in a minimally invasive fashion are so good. Way back when I first started doing this, people were still doing kind of open surgical dislocation work, where you go in and you surgically dislocate the hip and do the labral work and do the cam work. And it was always, from a salesman standpoint, it's not hard to sell 2 little tiny incisions or really big incisions. And I actually had a gal that had an open one on the other side, and I did her arthroscopy, and she's like, that was way better.
It's a ways down to the hip from the access port.
Even
that's a lot of tissue.
A skinny person, and it's all muscle.
Yeah.
So the ability to kind of delicately pierce through with a cannula that gives you access to there.
Yep.
And that's the challenging part about hips is like with a knee, you're like this far in, you poke in, you poke out. You don't need cannulas. But a hip, to lose your access into the hip that far down is like, oh man, you never want to lose your access because it's challenging to get that trajectory back. And that's why we leave cannulas in and we kind of do that and start to build that pathway back in there. It's remarkable how much we can do inside the hip. And that goes back to the point, it was like, people see 2 little tiny incisions, like, why does it hurt? Let's go back over those pictures. Shaved all this bone
We
here.
can still take bone out, even with a little tiny hole.
And
Do you ever show them the tool? This is what I put in your hip.
well, occasionally there's like pictures of stuff like that, because it'll be in the picture. I'm like, oh, what, is that still in there? No. That's not still in there. And like that, we have these, and it is remarkable the tools we have, the shavers and burrs, and how burrs have evolved. It used to be, because hips are fairly dense bone, and so to be able to burr that is different than like an acromion. Acromions, it's, you're hoping you don't take too much because the burr just digs in. Hips are like lean in there. So our ability to have better burrs, and that changed even like the difference between a good shaver and a good burr. It's 20-30 minutes in a case.
Right.
If your shaver kind of working and getting through tissue, and then the burr, especially you got a 20. I just did a collegiate, junior college quarterback, and his bone, you're just like sitting there.
Yeah,
But
solid,
fortunately we have these diamond burrs now that are just money, and that you can save so much time.
Wow, how about that? We use that on concrete.
Construction, diamond bladed saw blade. Diamond bladed.
Right. It's wood shop in there. Really.
It says DeWalt on it.
Oh, we get fancy tools.
That's the dumbed down version.
Yeah.
That's a couple $100 drill versus a $15,000 drill. That's the art. Don't drop the drill on the OR, right? Because that sucker.
Oh, they're pretty durable. I mean, because these are,
so.
they can get, water, blood,
wet,
and they get all
yeah.
kinds of stuff on them.
Yeah,
I mean,
sure.
so these are, that's why they cost so much money. Is because one, you use them
They work,
consistently.
yeah.
Yeah.
And, your drills are going to last you years, but that's why you're paying $10,000 for it. But you're going to get, many, many, many uses out of it. And they take a little bit of a beating.
Yeah.
And they're interchangeable with different, we get, the drill can turn to oscillating saw, it can be this and all these other aspects of it. And we talked a little bit about kind of the tools and kind of how we assault people, And,
Yeah.
yeah. If you're an ophthalmologist, you don't use a lot of oscillating saws. You're working around the eyeballs. I remember kind of a side story, but it's funny. One of our ophthalmology guys, the kid had got kind of shot with a pellet, and it kind of went through here and was lodged right next to his eyeball. And he didn't have an X-ray license, so he needed someone. And I was on the call on the weekend, and I was like, "Yeah, can you come in so I can do it?" Yeah, sure, I'll come in. Just because he can't run the X-ray machine. So we're in there, and he's like, "Oh, scrub in." It's funny. So we're literally, and he's like, "I don't know how to localize with these things. I don't ever use an X-ray machine because we take out a lot of foreign bodies and bullets and things like that. So we kind of figure out where you are in X-ray, where you have to put your hand to see this image." And so he's in there, and he's like, takes this little malleable sort of looks like a kind of a bendable tongue depressor, sticks it on the eye and moves it aside. I'm like, "Can you do that?" Dude, that's his eye. He's like, "Oh no, it's okay." I'm like, "No, it's not okay." The guy's just like, "What?" He's like, "No, it's okay." And so I'm reaching this little grasper in there. I'm like, "Can I reach in here and grab stuff?" He's like, "Oh, it's fine." I'm like, "No, it's not fine." Yeah. And it's just so funny. And I'm like, "Are you sure?" He's like, "Oh, it's fine." I'm like, But then you get people with all the broken pieces. They're like, "Is that fine?" Like, "Oh, that'll be fine."
Yeah.
It's just all your perspective of what
Yeah.
you do with it. But I mean, we have to kind of be always cognizant of the tissues we're handling, and some take more of a joke than others. Certain things you can just beat on all day and it doesn't matter. Tendons are pretty durable, ligaments are pretty good, nerves gotta be nice. Be nice. But some nerves are more durable than others. You look at one nerve and
It's over.
that's good. Yeah. Other ones you put a drill through, like, "Oh, okay, that's okay." They'll be fine. Yeah. So it's and then once again, kind of like the individualization. Some people's tissues are very different than others. And it's strange. You could have two exact same age people on the outside look the same, and get in there and just totally different tissue qualities, and it's just crazy.
I think that brings right back to what we were talking about a little bit ago about protocols. You're talking about so much individualization of tissues, people to people, area of the body. I mean, it's just amazing. I feel like I'm learning right now just so much in kind of how you're talking.
Yeah.
And it makes so much intuitive sense in the rehab world when the most thing that I care about is a mild progression week to week. And you kind of like, yeah, that's the protocol. Yeah, that's the op report. And I know it's either good or bad surgery, whatever. Where are you at right now? And then week to week, because in the end, it's all we really have because of what you're saying. So much customization to that person, depending on everything, of age to gender, to training history, to what they do for a living, to how much do they stand on their right hip. Yeah, I mean, everything that adds up to a life is so individualistic that you have to deal with. Under the scope, and then what we have to deal with on the table.
Yeah, one thing you brought up there is so important that we kind of ask people about. They don't always understand why we ask them, and it's like what they do for a living. Mm-hmm. Because your rehab job's different for a firefighter versus a guy who works at a desk. Not like they don't have similar goals of what they want to do, but the job requirements are far different. And people ask me like, "Oh, how soon can I go back to work?" Well, what do you do for work? Because if I do a hip scope on a firefighter, it's 6 to 9 months. Mm-hmm. Do a hip scope on a lawyer, back to work in 2 weeks.
Yep.
It's a big difference, huge difference, because of what you're trying to get them back to. Yeah. And the other question we ask a lot about, well, what's your house like? And you guys ask that too. Like, do you have stairs? Mm-hmm. Do you, because we hear it all the time. Like, well, where are we able to go up and down stairs? My bedroom's upstairs. Right? Well, you're going to plan your trips. Yeah. You're not going to, go up and down all day. You're going to come down in the morning, live in the morning, go back up at night. Mm-hmm. But yeah, the occupation thing, and it drives me nuts when our staff doesn't record that. Because they'll ask me, like, we'll get a phone call. It's like, well, hey, when can I go back to work? what do they do for work? Because that makes a difference.
Small detail. Yeah.
You know, and those are things that make such a difference because early on, that's, you know, that's like a big portion of our social history is, you know, well, what's your home like? You know, how many steps into your house, things like that you guys deal with all the time. Yeah. And then also, you know, what do you do? What do you need to do? You know, and then what do you like to do? That's you know, the different thing is because, you know, what do you do for a living? Then what do you like to do? So that's the big difference there too, is because you could have, you know, someone who works as a lawyer but loves CrossFit. You know, so okay, so this is what you do. So work-wise, yeah, we can do that. What you like to do, we're gonna have to modify. That's gonna have to take a little more time. Yeah. We're gonna have to work towards that. Yeah. You know, so it's a very different sort of phenomenon. And you know, you can always kind of tell. Because I always tell people, you know, at least 2 weeks of mental rest. You know, physically, yeah, we're gonna rest you, but you know, work causes stress and things that people don't realize. And you know, I want you to be mentally good to recover. You know, because that's such a big, you know, side of it is if you're stressed, and you guys see that too. You guys see so much of that stress that comes in their lives. Because they're worried about going back to work, or worried about this and worried about that, and those things impact their healing. And you can probably tell when you're working with somebody, like, what's that stress kind of? Because you can feel it. Man, you feel a little tighter. It's different today. Like, what's going on? You know, you felt good. Oh, and then you find out something's going on that's stressing them and impacting how this is healing. And what's going on there.
Anxious about looming events or something, you know.
Oh, whatever. And so that's, you know, I always tell them, like, hey, listen, you don't work for me, so I don't care when you go back to work. You know, so I'm going to let you go back when you feel ready and feel comfortable, then feel safe. You know, especially for the correctional officers, the firefighters, the police, those military, all those guys like that. Because it's not just your safety; it's the safety around you. You know, your team that's around you. You know, the firefighters, they depend on you if they get hurt for you to get them out of there, or whatever it happens to be. So those guys, I want them to I want you to mentally feel that you're ready to go back and be 100% on what you're doing. Because if not, you're going to be worried. And that's the same thing with the athletes. It's building that confidence. I always tell, you know, the athletes, when you first go back in, basketball, soccer, whatever it is, go out for 5 minutes, have the coach pull you out. You want that to be that first experience back after an injury positive.
Yeah, for sure.
Leave yourself wanting more. You know, that's where you get to be greedy. Okay, I work so hard for this, but then you go out there and like get a little taste of it. It's a little square of chocolate. Here you go. There's more where that comes from, but only this one right now. You know?
Right.
Savor it. Make it good.
Savor it.
You know, and so that experience that you want them, because there's the last time they were out there, they got hurt. That's their last memory, and that's scary. You know, and that's same thing. You know, that's when people go back to work. Well, I remember getting out of my car to walk to my office. It used to hurt so bad. So now, like, oh, I can do that now. And those little victories that they get, where they kind of realize, oh, I'm getting better now. And sometimes it's those little aha moments that patients, I'm sure you can tell you guys, and they come in and tell us, like, oh, I could reach and I did this.
And then we're the cheerleader again.
There you go.
But I still can't do all these things. That's all right. Hey, cheer.
Take a win when you can get it.
Take a win.
So
that's the season.
It's so crucial is the occupational side and in you know, I don't want to say spiritual side, but just the mental side, and that's where you guys have to really, because there's a lot of depression that goes along with
tremendous
pain. Pain makes you grouchy.
Identity loss.
And what you used to be able to do, and it's a struggle, especially with some of these young athletes, especially at their end of their high school career, and whether they want to go on to something else, or this is how I end it for me, and so you spend a lot of time talking to them, and I always have to kind of, if I can see that kind of on the horizon of, we may not be going back to this, you know, this maybe I'm not going to go back to soccer or this and that. You always have to give them, like, hey, there's, you know, many fish out in the sea sort of thing, you know. There's other sports, you know, this just opens you up to other opportunities, you know, in the sense, okay, you're not playing soccer anymore, but you may find something else, you know. There's a kid that went to Mike, he was, you know, a phenomenal soccer player, like really good, had a bad knee injury, wasn't going to get back, became a water polo stud. I mean, it's just shifted,
nice little pivot.
Athletes, and just moved and adapted and found something else, and went on and got a scholarship and everything else. Like, boom. So because sometimes, like the identity thing, they're so identified as this. You know, there's lots of other things you can do, and that's where we have to mentally help them along, and either, hey, we're going to get you back to that, or if we're not going to get you back to that, there's other things we can do.
Right.
You can find other stuff. You're still healthy. You're still young. There's lots of things you can do, and just that spiritual side of moving them along and
Yeah.
trying to work them through this hard time, because it's tough.
It is. So I want to talk about this other area, because a lot of this kind of leads to it, as far as using tech and the advancement of surgery and the what we do in rehab and tissue healing and such. Is this kind of like the pace at which we onset someone into the rehab process, or like a post-operative when to get started in PT situation? And I think this has evolved again a ton, and I think it varies heavily. So it'd be kind of fun to talk of. But one thing that's changed heavily is that because things used to be more open procedures, there was a bit more scar tissue and there was a bit more collateral damage. And as things have evolved, become more, in the sports medicine space at least, much more arthroscopic, less collateral damage. And like I said, we're slowing people down more than like trying to push them up, But still we see quite a variety in recommendations of when to start therapy. And this is fresh in my mind because of a gentleman today. He's 4 weeks post-op on a back, just a debridement of his spine. Not just, serious big surgery, but still wasn't a fusion, wasn't a disectomy, wasn't a disc replacement or anything major in that regard. It was a debridement and opening up some of the tunnels in the space. And the doc said, you can't start therapy until 6 weeks. And I knew him before he had the surgery, and he was in some pain, and here he is now. Like, he did pretty well for a week or two, and then he got really bad at 3 weeks post-op, and he's like, I haven't slept in 10 days at this point. I gotta do something. Like, I gotta come in, right? So I was like, well, come in, we'll be fine. Like, we'll be safe, And so I saw him on Tuesday. We did some very, very light, mild things, and just really educated him a lot on what to do and how to manage the situation. And the next night he slept 6 hours. I saw him again today, and he's like, my pain is gone from what it was. And so nonetheless, the point of all this is this idea of like when to start. And the message for me out there to the physical therapy or to the rehab community is, if you look at like an elite sports medicine institute, whether you're at HSS or if you're in Vail or if you're at Curlin Job or any of these places that are all conclusive, you've got ortho and you've got PT, and oftentimes the PT starts the very next day and certainly within that first week. But to do that, the skill of that practitioner has got to be high. You have to understand what the surgical process was, what they did, what's healing, and what you have to protect, and when what you can, probably not pushing anything at 1 week, but and what you can push, though, so to speak. So.
Oh yeah,
I know
I
we've
think,
talked about this.
And then you look at all the professional athletes.
Right.
They don't wait 6 weeks after their ACL to start rehab.
Right.
6 hours.
They're rolling in. They're at the bedside. Like, let's go.
Let's do this.
And
no more atrophy. Let's go.
There's I think, knowing what you do, and unfortunately, some things with fracture care, you just gotta wait for the biology.
Yep.
But other things, we know that if we get it moving passively and really keep everything else away from the injury site or surgical site healthy, it's going to be much better. There's plenty of research to show that if you keep one leg stronger, the other one doesn't get as weak. And that's
Every day I teach that.
every day. Yeah. So and it's real. It's not just. It seems like no. There's studies to show that. Perfect example is a girl years ago that you took care of she's a soccer player that had an ankle fracture. In her senior year, kind of early, wanted to go back for that senior game, and so everything but the ankle we crushed. She was doing everything. So and I was telling them, because we don't want to, like a throwing athlete, we don't want to get you back to your shoulder perfect. The rest you've just withered away.
Yes.
So
No good.
We got nothing.
Everything else has to be ready when your shoulder's ready.
Yeah.
It can't be like, oh, well, yeah, your shoulder's great, but the rest of you is no good. So that process, even if you can't do something specifically with that surgical site, there's an education piece of, we're going to go easy on this. This site's healing, but in the meantime, everything else has to still remain like we're ready to go.
Yeah.
And that's the great thing that you guys can do early on. And I think what happens is certain surgeons, you get burned by one therapist.
Oh yeah.
And you get one DVT, everybody gets prophylaxis. Like, that's the best idea. You're harming more than not by either not giving them access to it. And there's docs in the community that don't believe in PT at all. It's like, that's, it's overly broad, and,
Yeah.
and having trust in the therapist, and that's where, I don't care if you guys see a week, like, I got my PT set up for, 5 days out or 7 days out or whatever it is. I'm going to see them before I see you. Is that okay? Well, where are you going?
Exactly.
Oh yeah, go ahead. Because I know you're not going to abuse it. You're not going to, make it worse. You're going to have respect for what happened, but also educate them on this is safe, this is not safe, this is how you. Just like with your guy, it's a matter of just he probably was feeling good, and got off the range a little bit,
Yep.
and did a little too much, and then slapped his hand. And that's the whole part where the expectations is like, okay. You had surgery,
Yep. Yes.
That's a big thing.
Yep.
You have to respect that in the sense that your body's ability to do things pain-free, that was fine. But you still had surgery. Those tissues are healing. It's biology. You got to respect it. Be nice to it. Keep it happy.
Yep.
Quit when it feels good.
It's going to be a little hypersensitive to inflammation and inflammatory response. If
Yeah.
you blow it up, it's going to let you know.
Yeah.
right.
And it's
And
going to
I-
feel like day one again. And then,
And I tell patients, you don't know where that line to cross is until you cross it,
Yep.
and then you know. And then, but it moves too, because some days it may be 3 steps and you're good.
Yep.
Some day it may be 1 step and you're good. And you just have to kind of, be able to be flexible with it, and that's where you guys can teach them, like, hey, on the days you just feel good, do more.
Yeah.
Stretch a little more, try a little more. The days where it seems flared up, let it
Right.
be flared up, back off a little bit.
Yeah.
I'll tell people, they're too rigid. Oh, when can I get off the crutches? Okay, well, you can get off the crutches when you don't limp, And some days it may be you can walk the first half of the day, and then, your husband tells you, hey, it looks like you're limping a little bit. Good. Grab a crutch, grab a cane, reinforce that good gait pattern. But it's okay. First half of the day, feel strong. You still had surgery. You're a little going to fatigue. You're going to tire out.
Yep.
Go back to it. You're going out for a longer outing. Take the crutches.
Yeah.
Just always be good. Be nice to it. So when it does start to feel better, you're already ready to go because you've learned how to walk right.
Yeah.
And so it's those things you can teach people. It's like, sometimes you feel good and you don't need them. I can walk around my house without anything and I don't limp. Great, do that.
Right.
That's great. That's fine. But when you go out, take a crutch because you're going to tire out. You're going to fatigue. You're going to be not as good as you think you are.
Yep.
And then you're going to get into trouble.
Yeah.
You're going to start dragging and limping, and your
Yep.
back's going to hurt, and your other hip's going to hurt, and then we got to start fixing those things too.
Right.
So I think
Those are like,
and then the stuff you guys do with the BFR too is so cool.
Oh, yeah.
I mean, I love telling patients about that. If I know they're coming to you guys, it's like,
Yeah.
this is going to be amazing.
we tell them it's the worst feeling ever, but it is amazing.
Well, yeah. No,
you work for it, but it's
you work
biology.
for it.
When I
Yeah.
tell them, it's stressing, giving the muscles a stress that you wouldn't want to put that joint under right now. But the joint doesn't see that stress, but the muscles do, and they respond the way they should respond.
Yeah.
And so it's just, I kind of give them that brief explanation. It's like your muscles are going to feel like they're squatting 400 pounds, but your joint's not going to notice anything. And so it's like, okay, it's tough, but
Yeah.
but it responds.
Yeah. There's like a few key coaching points I think you bring up just in the last 5 minutes that I think I share with every single patient. I think we all do, or I hope we all do. But I feel like their rehab process or their healing process I describe as like the stock market. Like if you approach it as an expectation that some days it's going to turn red, you're going to be fine because it's just going to turn up to green. But it's going to do this undulating cycle with an upward trend. And then if you jack it up, it's going to plummet. But, if you can avoid that, unlike the stock market.
It's a correction.
It's a correction. It's a correction for you being a dummy. But either way. But you can expect that there's going to be this give and this take, but with big leaps forward, always approaching your, your healing limb as always feeling good, and you push it when you can, and you back it off when you can't. And then, it's like a personal pet peeve of mine to completely avoid 3 other limbs in a central section after surgery. Like it is profound when I watch someone maybe that I didn't treat, that I know went into surgery, and 6 months later they're more deconditioned than they were at any point in their life. And I'm like, you have an opportunity to raise the bar for the rest of your body so that your surgical side just catches up and then it's ready to go. Yeah. And as far as I'm concerned, an endocrine response to lifting with the other limbs is still systemic. So it's going to help your surgical side. 100%. And in a cardiovascular system is systemic when you stress it. And so if you stress it in safe environments where the surgical site is not affected, then their healing factors just went through the roof to try to get that side up to speed faster. So
I think as an industry, that's what we have to change. PT has to change where that, when you work on the knee, I'm not a therapist for your knee.
No.
I'm your PT. And it is treating the human. It is treating the endocrine system and the aerobic system and the joint system when appropriate. And I think that mindset needs to shift because I think every fusion I've seen, a spine fusion, I can almost say, oh, yeah, your doctor's for sure not going to let you see me for 12 weeks. And I can promise you there's stuff to do. And it's weird how they all do 3 months, for a fusion. They all do. But, there's other things to do. Like make sure your neck moves well because it's going to get kinked. But we have to just change that and bit by bit.
Yeah. I mean, because it's whenever I hear somebody come back and, okay, so what are they doing with you? If I hear something other than that joint, I'm like, all right. That means, all right, they know that there's more to use than just this knee. Because the knee doesn't work in isolation. You know that. Yeah. I mean, if I sit here and bend it back and forth, yeah, it's kind of doing that. But my core stabilizes me so I don't fall off the chair. Everything else is still kind of engaged there. And so when I just, the ice stem, and a couple of things that you had said that I want to kind of bring up is, you'll see people in second opinions that, had a surgery, this and that, and like, oh, I think I need another surgery. And you get there and you evaluate it and like, no, you don't.
Yeah, right.
You're just horribly deconditioned.
You just didn't finish.
Like,
you started something and didn't finish it.
You're like, and then it's kind of that expectation of like, well, how bad were you? How long were you hurt before you had surgery? Oh, it's 2 years. Okay, we're 8 months after surgery. Somehow you think you're going to make up that time that you had 2 years of being bad. Like everything around that joint went to just trash, and now you're 8 months after surgery. Your surgery, X-rays look good. Your MRI things like it's fine, and whatever it happens to be, the body part. I don't see anything there that needs reoperation. Everything's in there. You're just not conditioned to make that joint work well, and it's just a matter of telling them, and then you kind of show them like, well, can you do a single leg squat?
Yeah.
Nope. And before you try to, let's bring this heel. Okay.
Yeah.
Okay. This one's like this far from your butt. It's like,
right.
You're just not
Clear markers.
Yeah. And then they kind of start to see it a little bit, and because they're coming in like, oh, I need another operation. I need another surgery because this one didn't work. Yeah. It's like, no, it worked. I think it looks, your surgeon did a good job.
Yeah.
You just need to get in better shape, and that's the hard part because they just want the surgery to be better.
Yes,
it's like
that's right.
Instantaneously.
Expectations.
They want to be fixed. It's not really fixing things.
I hate that. I hate that term.
Yeah. To a young person, I said, if you think of fix, would you ever fix a flower? Because you're a growing human.
Yeah.
You are growing.
Yeah.
You don't fix flowers.
Yeah.
You can nurture them.
Yeah. And the other thing is,
I know, weird.
I want to be normal again.
That
works.
And so,
I want to be 10 years ago.
And I tell them, it's like,
I'm gonna use that,
if your car's in the trash, we're going to
abstract.
paint it. We're going to make it look good on the outside. It'll be functional. But you're always going to know that car was in an accident. And so I always tell them, don't use the word normal. I'm not going to fix you. I'm going to make you functional.
Yep.
And that's, there's a big thing between, I have normal range of motion. Functional range of motion. I can do this, but how many times do I really need to do this in a day for what I do?
Yep.
If you're an electrician, you work overhead, okay, you need to do that a lot. So yes, we need to get you functional here.
Yep.
But if you work in this space most of the time, if you can get to here, who cares? You're still functional. You can get something off the shelf, you can do whatever. So dispelling that when fixing and normal and all these things.
Throw those words out.
Yeah. I'm going to make you functional because that's what you do. You function.
Yeah.
You're not normal. It's like, well, what does that mean? What does normal mean? Because my elbows don't straighten, Sure. And so that's normal for me, but most people elbows can straighten. And that's.
Well, I can fix it.
But I can function. I can do whatever I need to do. I don't need it to be straight for what I do for function.
True that. You're best off with your arms a little bent.
Yeah. So I mean that's that term fixing. Oh.
That's what they're looking for.
Yeah.
And but they're not eating right, they're not sleeping right, they're not doing the good things that actually allows their body to self-heal, but they're looking for you to fix me.
Something you guys had brought up too is, sometimes you can't fix them because they're so bad on the other end of either nutritionally or mentally or in the endocrine systems, blown up. And so, and that's where it's sometimes hard. You have to most people are kind of good, but when you see everything's done right, but they're not going right, what's that thing that's, they're ramming their head against and doing it, and it's either nutrition or sleep or, some outside stressor that's holding them back. And that's where, a good therapist can really just kind of dig in there, and because you have that much more time, in a 10-minute, 15-minute appointment, that doesn't always come out.
Yeah.
And then
It's hard to find even after 4 hours with a person. It's a lot of discussion. to
you
kind
guys
of
spend
get
so
to
much time,
Yeah.
I know specifically is delving into what they do. I mean, from some earlier podcasts, you kind of talk about it and just kind of figuring out what they do and why they do it or why they need to do it. And that's because then you can help them. When you know where they want to go, you both have a spot on the map. If you're just kind of fixing their knee,
Right.
and you don't know where they're trying to go.
Right.
No.
Right.
Very
Lost.
surface oriented.
Totally.
Yeah.
Yeah, it's a big deal.
That's it.
Good, man. This has been fun.
Yeah.
It's good to have you. Thanks
Absolutely.
for coming on. And the wine was excellent, too.
It was
It's a good
fantastic.
call. We
Yeah.
got some better comments at Arrest with the wine as well. I think that was good.
I just took one or two. It was great. I love Pinot. Love it. It's the only thing. It's the only wine I
so
drink.
good.
I didn't tell you that either. It's the only wine I drink.
Look at that. Well, I think it would be something nice and light to enjoy. And
I'm very
nothing
light.
Too heavy.
so I
and-
need-
Don't you make sangria?
With Pinot. Yeah, I'm sure you're not supposed to do that, but that's what I.
There's no rules on that.
It's their own individual
Do you
taste,
like
Russ.
it?
Yeah. Do you like
I
it?
do. I do.
You know,
Not a lot of it though,
matters.
but I like it.
I heard this today. It was with banana peppers. You put peanut butter on them, and I'm like, I don't know, I'll try it. Yeah. So I guess something about the. I'm like, yeah. So I'm just gonna try that. I'm like,
A little harmony there, huh?
Yeah, it was all right.
Wow.
I love both of those. So.
Yeah, you can try them together.
All right.
Just not at work. I don't have to smell you. It's fine.
I'm gonna put that right in the tuna, dude. I'm gonna get the tuna. I'm gonna get the
God.
banana peppers and peanut. Oh, that's gonna be a little weird, maybe.
Thank goodness we're wearing masks at this
Maybe
point in
we're
life.
thinking that
You do not have advice on Russ's food choices.
He said
Very
tuna
commonly
in the
known.
He said
workplace.
tuna in the workplace.
Tuna in the workplace.
Happens frequently.
I know, at least twice a week. It's my
Least.
go-to.
I
Standard.
could care less about any comorbidities with it. Just go for it. Scoop of peanut butter just right out of the thing.
HR violation. I think. I don't know, it's gotta
Multiple times over.
It's uncontrollable. We're just happy that he eats and he goes back to treating. So.
be. Yeah.
There you go.
Well, cool. Well, thank you guys for thanks for coming.
Oh, absolutely.
Thanks for
Thank
talking.
you.
It's
Great to have you.
And thank you for all that you guys do. Like I said, I always tell my patients this too. It's like, you guys make me look good. I do my operation, but you guys really make me look good, and in what you guys do, and nothing but 100% praise for you guys. And I mean, time and time again, they come back and thank me for sending to you guys, because like I've been to therapy before, but this wasn't. Apparently, I didn't have therapy. It's like, this is what therapy should be like. It's like before they just the stem and ice and this and that. And it's like everybody that comes in, it's like oh. I need to, oh, you're going to work. Be careful what you ask for. You will leave there like, I did something. That's what they say. Like, I felt like I went there and I did something.
Yeah.
Not just lay on a table. Have somebody move you around a little bit. It's like, you do that, but I mean, they leave here knowing that they did something to move them forward in the direction they want to go.
Yeah, I
So
appreciate
that's
that.
Yeah,
where I mean
absolutely.
it's and I wish I could send everybody, but and unfortunately there's insurance, and they don't always let me send everybody, but
Yeah.
because you guys do such a phenomenal job.
I
Thanks.
appreciate it very much.
Yeah.
That's what it's designed to be, as a model where people can do that. They can find a place to move, and they can move better and get that function back, get that life back, and we can help coach them through it. So, all right, well, thank you guys. Thanks for watching Kimecast. This was Kimecast, and we are the Kime Human Performance Institute. Thank you very much for listening. We'd love to continue the conversation with you. Please hop on our social media. It's at KimeHPI, and engage with us there. If you'd like us to feature a topic or answer any questions live on the show, post your comments there. You can also check us out on our website at kimeperformance.com, and there you can see links to content that we've posted throughout our podcast for more information.